All right, it looks like most people are rolling in. Give it a second here, but it looks like the attendee numbers have slowed down. So welcome everybody. Thanks for joining us this evening. We're going to do the first of our two ABSITE reviews this evening. So this is kind of your early primer for the ABSITE. You still got a while to go, but it's a good time to get started. My name is Tim Vreeland. I'm a surgical oncologist in San Antonio, Texas. And Jessica Zaman is my co-moderator for tonight. And then we have three residents that we'll introduce in a bit. So just we'll get started with a couple introductory slides here. So as you see, that's our title for tonight. You can keep going. This is sponsored by the Resident Fellow Education Committee. We'll just mention that. So again, there's myself and Jessica who will be co-moderating tonight. And there's our the SSAT Twitter handle. So it's a good follow, lots of updates, announcements, and then there's some, good journal discussions and such that are primed by that Twitter handle. So if you don't follow the SSAT, you certainly should start tonight. All right, next slide. And just some webinar tips. I think by the end of 2021, we probably all know how to do this at this point, but, mute your microphone when you're not talking, be mindful of background noise when possible. Most of you will not be on camera tonight, so that's really only applies for us. And then, I think that this is a 2-hour webinar, so, it will be recorded. You can go back and watch it again, but, while you're here with us, try to limit distractions and focus. It's going to be it is 2 hours long, but there will be a lot of good content, a lot of high yield stuff. So do your best to pay attention. We are going to intersperse questions throughout the talks tonight. So, try to answer those questions in your head so that when they give you the answer, if you're wrong, that'll sort of trigger you to remember that little factoid that they're going to give you after the question. Next slide. And again, a copy of this recording will be available on the SSAT website. So I highly recommend that you review this again. You can listen or watch while you're doing other things to the recording. And I think that, that's super helpful. The repetition of hearing this information a few times will really help you on the day of the ABSITE. The SSAT has a YouTube channel with all the webinars and a bunch of super helpful things. So check that out and subscribe on YouTube. And then the podcast, which Jessica will talk about at the end, SSAT Soundbites, also puts a lot of the webinars on as podcasts, so audio only as the podcast. And then there's a bunch of other great episodes as well. So definitely check the podcast out and subscribe to that. A lot of great stuff there. Next slide. I think Jessica's going to take it from here. Enjoy, everybody.
Welcome, everybody. So I really highly recommend the Society for membership. I joined because I like it because it's multidisciplinary. I'm a bariatric surgeon, and so sometimes I forget some of the surgical oncology and colorectal type of information. So I think this is a great society for any specialty. And I think that we really do have a lot of stuff for education. So even when you're a resident or a medical student, I think that it's very helpful. You also get a subscription to the Journal of Gastrointestinal Surgery, and then you get discounts to the Digestive Disease Week because our annual meeting is at the same time. Other things is that you do get access to apply for awards, grants, and scholarships, as well as different fellowships, and a lot of really great leadership opportunities. So this is the lineup for today. So with this, I'm going to introduce, so we will have, we're introducing, then we will have Dr. Tyler Robinson presenting on bariatric, foregut, and hernia topics. And then we have Kavina Juneja from University of Alabama talking about trauma critical care. And then finally, we will have Dr. Thomas Ward talking about colorectal and small bowel diseases. We are trying something a little different this year. Previously, we had mostly lecture format, but this year we're trying to tie it in with some questions, just because sometimes with the virtual format and any format, I think the questions really help solidify some of the information that you're hearing in a rapid fire fashion. A little plug for our podcast. So If you liked the webinar, you thought it was helpful, then you can listen to it again in your car on the way to work. You can listen to it several times if you need to. So our podcast is called SSAT Soundbites, and it has multiple goals. So a lot of the webinars are converted to podcasts so that you can listen to them on your own time. In addition, we have monthly interviews from authors in the Journal for Gastrointestinal Surgery. We have a partnership with them. And so the editors select articles that they think are interesting, and we do articles from all types of specialties. And then the last thing is there are a lot of other interesting series, such as like the Mentor of the Month. And then we're trying to do some like, interesting debates between people who are leaders in surgery in their specific specialties. So there are a lot of really exciting things that we have planned for the future. And that, without further ado, I am going to hand it over to Dr. Tyler Robinson, who is a general surgery resident, a chief resident at Albany Medical Center, and is pursuing a fellowship in MIS surgery.
All right, hello everyone. Thanks very much to Dr. Zaman and Dr. Vreeland for the introduction, for the SSAT, for the privilege of presenting this evening. Let me just pull up my slides here. Hope everyone's studying is going well. All right, so let's see if I can minimize this. So again, I'm Tyler Robinson, Albany Medical Center. I'll be presenting on MIS, Foregut, and Hernia. So no relevant disclosures. Obviously, this presentation is not meant to be comprehensive. These are all very large topics and impossible to really get very far in any of them in just like 25 minutes. So we'll jump right in. Just wanted to also indicate the category weighting for all of these. I think this is a good way to actually guide your studying. It's impossible to, try to digest all of this material just for one annual exam. So you can kind of use these weightings to actually appropriately target the topics that are going to be most commonly questioned on the exam. So with regards to my talk, hernia is about 2.5% of the ABSITE, esophagus 2.5%, stomach 3.5%, minimally invasive surgery is only 1%. You can get that breakdown by scanning the QR code in the bottom right. And I also just wanted to plug SCORE. There's a lot of different study materials out there and a lot of different question banks, but SCORE has really gotten really good in my opinion, and it's also written by the American Board of Surgery, who also writes the ABSITEs. And in addition, SCORE puts out this curriculum outline. There's not a series of learning objectives or a curriculum for the ABSITE itself, but I think this is as close as it gets. And I think, again, in terms of targeted studying, efficient use of your time, I think this is a good resource. You can scan that QR code to get to that curriculum outline. Jumping right in, minimally invasive surgery. There's 3 learning objectives listed on the SCORE website: minimally invasive surgery principles, robotic surgery principles, and safe use of surgical energy. So we're going to jump into questions. You are preparing to perform a procedure in the operating room for which of the following would laparoscopic surgery be indicated? A, small bowel obstruction with massive bowel dilation in a male patient. B, cholecystectomy in a woman who is 24 weeks pregnant. C, ventral hernia repair in a man with a history of heart failure, ejection fraction of 15%, and hemodynamic instability on insufflation. D, inguinal hernia repair in an 84-year-old man with atrial fibrillation and uncorrected coagulopathy. E, traumatic abdominal injury with a woman with hypotension. I'll give you a couple of seconds. Try to answer that question in your mind. All right, hopefully you guys all picked B, cholecystectomy in a woman who's 24 weeks pregnant. So pregnancy is not an absolute contraindication in any trimester. It's historically believed to be safest in the second trimester. First trimester, there's an increased risk for spontaneous abortion. Third trimester, an increased risk for premature labor. The other selection choices were either relative or absolute contraindications. Hemodynamic instability is an absolute contraindication. Massive bowel dilation would make laparoscopy prohibitively difficult. Uncorrected coagulopathy is unsafe. And then someone who's got advanced heart failure may not tolerate insufflation. Pneumoperitoneum, there's always a question on every single year on the ABSITE about some of the hemodynamic effects of laparoscopy and pneumoperitoneum. You can just think about if you put a big mass and it increases the pressure within the abdomen, that this is going to increase your mean arterial pressure. increase your pulmonary arterial pressure, peak inspiratory pressure, systemic vascular resistance, central venous pressure, and mean airway pressure, and then decrease your venous return, your cardiac output, and your renal flow. A question that is frequently asked on tests and is also clinically useful. This happens not infrequently. So bradycardial insufflation is caused by decreased venous return to the heart, and the immediate response to that is to release pneumoperitoneum. So take out the insufflation tubing, open up one of the trocars, and decrease the pneumo, allow anesthesia to catch up. And then you can attempt to re-insufflate using a low flow. So oftentimes we just kind of jack up that flow rate to the very maximum, especially if we're using a lot of suctioning, if we're doing a lot of electrosurgical dissection. But especially with someone who's got perhaps some degree of heart failure, having a low flow, low pressure, and then titrating up there as your exposure requires is the safest thing to do. While working the pelvis during a low anterior resection on a 77-year-old woman with a mid-rectal tumor, a bleeding vein is grasped with the DeBakey forceps. What monopolar radiofrequency energy setting should you use to provide the best vessel seal? A, 30-watt cut mode, B, 30-watt coagulation or coag mode, C, 30-watt blended mode, D, 60-watt coag mode. All right, hope everyone's answered in their head. The answer is A, 30-watt cut mode. There is pretty widespread misinformation and misunderstanding about how actually to use the electrosurgical unit. Cut mode creates a homogeneous seal. Coag mode does not provide additional coagulation to coapted vessels. So I just also wanted to pitch the FUSE course. This is run by SAGES. It's like the fundamentals of laparoscopic surgery and fundamentals of endoscopic surgery. It's called the fundamental use of surgical energy. So a cut mode, as you can see on the upper left here, its duty cycle is 100%. So there is 100% of the time there is actually current flowing through the tissues, and it's a lower voltage versus coagulation has a higher voltage, but it actually is only generating current through the tissue at 6% of the time. So what cut does is it also is known as vaporization. So it rapidly heats cells to above 100 degrees centigrade. So it vaporizes cells. They just kind of explode in steam. So there's no desiccation and coagulation and denaturation of proteins, such as in coag, which doesn't heat cells to quite as high a temperature. So if you're actually coapting a vessel, so you can see in this picture here, if you're actually holding a vessel closed with an instrument like a DeBakey forceps, then you apply monopolar energy with a coagulation mode, there's actually incomplete vessel sealing. But if you use a cut mode, there is a complete vessel sealing. So this is was a question that is on score and also is clinically useful. I also recommend the FUSE course. So on to Foregut. There is the learning objectives listed by score for esophagus here. Motility disorders is high utility. We'll get to that. Benign and malignant esophageal neoplasms, perforation, Barrett esophagus, hiatal hernias. You need to know about caustic ingestion, and then anti-reflux procedures, myotomies of various types, repairing perforations, and esophagectomies and esophagogastrectomies, as well as paraesophageal hernia repairs. All right, a 52-year-old woman presents to your office complaining of food that gets stuck in her esophagus and persistent epigastric pain. You perform an esophagogastroduodenoscopy, which shows esophagitis. An upper gastrointestinal series reveals a type 3 paraesophageal hernia. You order manometry testing, which reveals impaired esophageal motility. What is this patient's best surgical option? A, laparoscopic paraesophageal hernia repair with Nissen fundoplication, or with Colles gastroplasty, or with Toupet fundoplication, or with a gastropexy. I'll let everyone answer that in their own minds. Hopefully you picked C with Toupet fundoplication. Score's answer indicates that this person has impaired esophageal motility and thus would be relatively contraindicated to a Nissen, which might increase postoperative dysphagia. The callus, gastroplasty, and gastropexy are not indicated for this patient. So 4 types of paraesophageal hernias. Type 1 are sliding, just due to laxity of the frontoesophageal ligament and displacement cephalad of the gastroesophageal junction. Type 2, the gastroesophageal junction, the Z-line is actually appropriately located anatomically at the diaphragmatic hiatus, but then there is a paraesophageal herniation of the gastric cardia, or sometimes even the fundus. Type 3 is a combination of type 1 and type 2, and type 4 is any paraesophageal hernia that also contains any other organ other than the stomach. So then everyone should know this if you've passed 30-year medical school. So a Nissen funnel application is a 360-degree wrap. A toupee is a posterior wrap. That's typically about 270s. A door, you slam the door shut on the esophagus, and in a toupee, you typically use if you're bald, and if you're bald, then you sometimes have a little bald spot in the front. Callus gastroplasty is for foreshortened esophagus. You cannot completely reduce into the abdomen, and so you can make this stable line to actually make a neoesophagus and then use the residual fundus to provide your wrap. Esophageal motility is a pretty high yield thing to study just before the ABSITE. Hop on Google Images and take a look at some of the high resolution manometry. I think typically they would probably show a picture of that and try to ask you how to which esophageal disorder they're indicating, or perhaps a second order question would be what the treatment would be. So the Chicago classification of esophageal dysmotility is basically grouped in 2 different classifications. Disorders of esophago-gastro junction outflow, which include achalasia, or esophago-gastro-junction outflow obstruction. And those are all kind of gradations, achalasia 1, 2, and 3, and then the outflow obstruction are all kind of gradations. All of those include a hypertensive lower esophageal sphincter that fails to relax. Down at the bottom, the outflow obstruction is with basically preserved peristalsis. And then if you go all the way up, achalasia 3 has got some spastic peristalsis, achalasia 2 has got a little bit less peristalsis, and then achalasia 1 has, the hypertensive lower esophageal sphincter, but really no peristalsis at all. That's the kind of classic bird's beak blown out esophagus. And in the end stage, it can actually create like what they call a sigmoid esophagus, which is really tortuous and dilated and doesn't work at all. Disorders of peristalsis, there is absent contractility, distal esophageal spasm, which is the corkscrew esophagus you might have heard about, hypercontractile esophagus, that's a nutcracker esophagus, and ineffective esophageal motility. We're going to go through a couple of those pictures really quick. Normal, you see a normal peristaltic wave, and then importantly, a relaxation of the lower esophageal sphincter right after initiation of the swallow, indicated by the arrow. With achalasia, there is hypertensive lower esophageal sphincter tone that's greater than the upper end of normal, is about 15 millimeters of mercury, and it fails to relax, and then there's no real ordered peristalsis. So with the outflow obstruction, there is an ordered peristalsis. It's a little bit hypertonic, but then again, failure of the lower esophageal sphincter to relax. Absent contractility is pretty clear. There is LES relaxation, but there is no contractility. Just also wanted to note that achalasia is actually a pre-malignant lesion, 8% of incidence of carcinoma at 20 years, and the most common is squamous cell. I think that's probably kind of a high yield topic or factoid. And then you can see the bird's beak dilated esophagus there. Diffuse esophageal spasm, that's the corkscrew esophagus there. Really no coordination of the peristalsis. Hypercontractile does have a coordinated peristaltic wave, but it is hypertonic and leads to, that's actually the most painful of all the esophageal dysmotility or disorders. And then the ineffective is where you have an attempt at a peristaltic wave, but it's just ineffective at propelling a bolus of food across the lower esophageal sphincter. Next question. 60-year-old.
Hey, real quick,
Yeah.
Tyler, just to throw in a question. So there was a question in the chat. Do you often see impaired motility improve after the hiatal hernia is repaired? And then, Dr. Zaman mentioned, yes, that it usually does improve. But I think that question boils down to, would you do a full wrap? You know, would you sort of bet on the fact that it's going to get better and do a full wrap? Or are you always going to do a partial wrap when you see impaired motility, which I think is what the question is getting at?
Sure. Yeah, definitely. We would veer towards doing a partial wrap. And actually, the article talks about doing a door, which is an anterior instead of a posterior fundoplication, because that's kind of what was done for achalasia, and it's worked in all the past years. But yeah, absolutely, we would not do full wrap in a patient with motility.
Great. Thanks.
All right, thanks very much. I can't see the chat, so thanks for the interruption. All right, we're going to keep jamming along. 68-year-old man with a history significant for gastroesophageal reflux disease presents with a recent weight loss and worsening dysphagia. Workup includes an esophagram, which reveals a distal esophageal mass. Endoscopic ultrasound with a biopsy reveals a T1A esophageal adenocarcinoma with no evidence of nodal involvement. There's invasion in the superficial submucosal space between the lamina propria and the muscularis mucosae. That is not the submucosa, that is a superficial submucosal space. The depth of invasion in the mucosal layer is now called M1, M2, and M3, and those really relate only to T1A lesions. Only M2 and M3 invasion is associated with lymph node metastases. Which of the following is a characteristic of this M3 lesion? A, this esophageal tumor is amenable to chemotherapy treatment alone. B, lymph node involvement is not related to the depth of the esophageal tumor. C, this esophageal tumor may spread through superficial submucosal space lymphatic channels located in the lamina propria and tissue between the lamina propria and the muscularis mucosa. This risk is greatest in M3 lesions. D, T1A esophageal tumors invaded in the submucosa. All right. Kind of a wordy question and wordy answer. The answer is C. And there's a pretty lengthy explanation here. But the point is T1A lesions have pretty low risk for lymphatic involvement. Once you start having a T1B and certainly a T2 lesion, now that tumor is invaded down into the submucosa, across the muscularis mucosa, and is now directly involved in the very extensive lymphatic drainage of the esophagus. The most important prognostic indicator for esophageal cancer in the absence of distant metastatic disease is nodal status. So again, T1B, T2 lesions, that's when you really start getting the drop off in mortality. So again, you probably have all seen these pictures before. Take a look at it before you enter into the test. T4 is involving some other organ in the chest, aorta, pleura, the heart itself, lung, spine. T3 is extending across the adventitia. T2 is extending into the muscularis mucosa, and then this T1 up on the left side, if it doesn't cross the muscularis mucosa, it's a T1A, and if it does, it's a T1B. And the T1B, that's where you really have the drop off in terms of having increased risk for nodal metastasis. So I'm going to go pretty quickly through this because I know we're probably kind of getting short on time. Squamous cell carcinoma and adenocarcinoma are the two types of esophageal cancer. Risk factors are included there. Squamous cell tends to be more proximal and is more common globally. Adenocarcinoma more distal and is more common in the United States. We've got some differing risk factors. Tobacco is common to both of them. Presentation, both with dysphagia, history of reflux, often in adenocarcinoma, retrosternal pain, anemia, fatigue, weight loss, diagnosis by esophagram, and endoscopy with a biopsy demonstrating carcinoma. And staging is by EUS. So EUS will both tell you a clinical T stage as well as your nodal status. CT PET scan looking for distal metastases. Squamous typically goes to the lungs. Adeno typically goes to the liver. In management, T1A are amenable to endoscopic resection. The risk of nodal involvement, local recurrence, and cancer-related death is low following their resection. But anything that's more than T1A, T1B, tumors greater than 2 centimeters, or poorly differentiation should be considered for esophagectomy. And then T2, you've really let the horse out of the barn. And by that point, those tumor cells are likely in your lymphatics. So T1B all the way up to a T4A resectable, extensive local regional disease that is not widely metastatic, should be considered for neoadjuvant chemotherapy with a fluoropyrimidine-based chemotherapy drug, followed by esophagectomy. Unresectable tumors include extensive involvement of the heart, great vessels, trachea, adjacent organs, or multi-station bulky lymphadenopathy. Supraclavicular nodal involvement is M1, non-regional nodal disease, and other metastatic disease. All right, 64-year-old man with a history of long-standing gastroesophageal reflux disease has recently been diagnosed with distal esophageal adenocarcinoma after undergoing esophageal gastroduodenoscopy with biopsy. He is scheduled to undergo an Ivor-Lewis esophagectomy. When performing the operation, you were careful to preserve which of the following vascular structures in creating the gastric conduit? A, right gastroepiploic artery, B, left gastroepiploic artery, C, left gastric artery, D, gastroduodenal artery, E, short gastric arteries. All right, hope you guys chose A, right gastroepiploic artery. The right gastric artery is oftentimes maintained, but the primary blood supply is the right gastroepiploic artery. The left gastric and the left gastroepiploic arteries, as well as the short gastric arteries, are all taken to mobilize and make the conduit. Margins in esophageal cancer are kind of poorly defined. NCCN actually just regards it as R0 resection in terms of your post-operative management, so no tumor on ink. Typically your distal margin resection is not hard to obtain because you're going down to the conduit, so you've got a lot of stomach that you can resect onto. And then proximally, most surgeons, I think, would do like 1 to 2 centimeters. Preoperative EGD and bronchoscopy for upper and middle lesions, make sure there's no airway involvement. So there's 4 different types of reconstruction options and surgical approaches. And Ivor-Lewis is typically an abdominal approach with a right-sided VATS or a thoracotomy, and this can either be an open approach or a minimally invasive approach. All of these require a pyloroplasty and a mobilization and the creation of the conduit. One thing that could be testable on the ABSITE is the relative risks with each of these approaches. So an Ivor-Lewis has an interthoracic anastomosis, and those leaks can be highly morbid. And then there's a limited proximal resection. So these are typically performed for tumors of the gastroesophageal junction. A 3-hole mecone approach includes a cervical incision as well. These are better for upper esophageal lesions like squamous. The drawback is the 3rd incision. There's a little bit of a higher leak rate, although they're less morbid since the leaks occur in the neck. A left transthoracic approach, I've never seen this. Sounds pretty interesting. You actually cut through the left chest and then cut through the diaphragm and provide all of your mobilization, your pyloroplasty, and then your anastomosis in the left chest. There's a limited proximal resection. You do have excellent exposure, apparently. And there's a potential for interthoracic leak. And then finally, the transhiatal, which is always a very dramatic picture defined in the surgical textbooks. I've never seen this done. Laparotomy and a neck incision, but no chest incisions at all. No difference in overall survival, though it's thought to have an inferior oncologic resection. Alternatively, you can use colon and or jejunum with a room-wide construction. These can be pedicled or free grafts with microvascular anastomosis, typically to the carotid. Complications include esophageal leak, conduit necrosis, chyle leak if you're doing the McCone dissecting in the left neck, a recurrent laryngeal nerve injury. All right, on to stomach. So some objectives for stomach, functional disorders of the stomach, adenocarcinoma, other neoplasms, GISTs, bleeding, foreign bodies, morbid obesity, including bariatric surgery, peptic ulcer disease, and all of the resections and surgeries related to those conditions. A 65-year-old woman has a recent history of gastrojejunostomy following a surgery for peptic ulcer disease. She has symptoms of abdominal pain, early satiety, and diarrhea 30 minutes after eating certain foods. What is the likely diagnosis? A, diabetes mellitus, B, dumping syndrome, C, bowel obstruction, D, marginal ulcer, E, gastroparesis. All right, hopefully you guys picked B, dumping syndrome. Post-gastrectomy syndromes include dumping syndrome, as well as metabolic disturbances, afferent loop syndrome, efferent loop obstruction, alkaline reflux gastritis, and gastric atony. Dumping syndrome, most common after Billroth 2, less common with a Billroth 1 or a vagotomy or pyloroplasty. And there's kind of two different types. Early would be a passage of highly osmolar food into the small bowel. And there's a whole bunch of fluid that then dumps into the small bowel, rapid overdistension, leading to bloating, nausea, vomiting, diarrhea. Late, which is much less common, are carbohydrates that are quickly absorbed by the small bowel, leading to hyperglycemia and a reflex hyperinsulinemia with a rebound hypoglycemia, prompting a catecholamine surge, which is symptomatically experienced as diaphoresis, tremors, tachycardia, lightheadedness, and confusion. You evaluate a 6-year-old boy according to his mother, who swallowed a button battery of unknown size 3 hours ago. Boy's vital signs are stable and within normal limits, but he reports moderate epigastric pain and nausea. His abdominal examination reveals a soft, non-distended abdomen that is tended to palpation over the epigastric region. An abdominal x-ray is taken, which shows a 25mm button battery. What is the next step in the management of this patient? A, this patient should go for an immediate CT scan of the abdomen or pelvis. B, after initial imaging confirms the location of the battery in the gastric lumen, the patient should be observed with repeat radiographic films in 48 hours. C, after imaging confirms the location of the battery in the gastric lumen, the patient should be taken for emergency endoscopic retrieval. D, the patient may return for a repeat x-ray in 10 to 14 days for follow-up radiography with endoscopic retrieval of the battery if it has not passed. E, the patient should be immediately taken to the operating room for exploratory laparoscopy. All right, answer is C, emergency endoscopic retrieval. And the kicker in this question is that this patient is symptomatic. Warrants emergency endoscopic removal. He is reporting moderate epigastric pain and nausea. So battery ingestions occur in 1.5 per 10,000 children years in the United States. Serious sequelae occur in only 2.7% of button battery ingestions. Worse with a greater size of the batteries, larger than 20 millimeters. And the guidelines do vary. This is what I'm going to use for answering test questions and also probably clinically. If any symptomatic patients require emergent endoscopy or go to the operating room if you have a concern for perforation. If they're asymptomatic and the battery's in the stomach, then you could try to get it out with urgent endoscopy within 12 hours. After that time, it's not likely to be in the stomach anymore. Asymptomatic with the battery in the small bowel, you can observe them at home. You don't need to admit them. Asymptomatic greater than 12 years old, button battery less than 12 millimeters, even if it's in the stomach, you can still observe them at home. They should be checking their stool, and if there's no passage at 10 days, you should get an x-ray to see where it is. All right, an 85-year-old man presents to your office with significant weight loss, early satiety, and epigastric pain. He undergoes esophageal gastroduodenoscopy and endoscopic ultrasound, which showed T3 N2 stomach cancer. Positron emission tomography demonstrates a large lesion in the liver and a small lesion in the lung. The man is diagnosed with stage 4 disease that is unresectable. He wants to know what this information means. What do you tell him? A, he has a 5-year survival of 50%. B, he has a 2-year survival of 50% and a 5-year survival of 5%. C, he has a median survival of 3 years. D, he has a median survival of 3 to 6 months. Are you an optimist or a pessimist? Should be a pessimist with stomach cancer. It's pretty comorbid. Very poor prognosis. All right, gastric adenocarcinoma risk factors include dietary nitrates, smoking, H. pylori, and genetic diseases, as well as gastric polyps, increasing risk for cancer with increasing size. Presentation, vague visceral pain that's unrelated to oral intake, early satiety, weight loss, dysphagia from proximal lesions, obstructive symptoms from distal lesions, and anemia. Diagnosis is by endoscopy and biopsy. Staging is by EUS, similar to esophageal carcinoma. You can get both a T stage as well as nodal involvement, but because it's down on the stomach, you can actually get an FNA of suspicious nodes, and then a CT or PET scan to work up distal metastases. In terms of actual pathologic staging after your resection, there needs to be at least a minimum of 16 nodes in your resection, and greater than 30 is ideal. And again, like esophageal cancer with T1 tumors, endoscopic mucosal resection is typically adequate treatment. It certainly is important for staging. Total gastrectomy is usual for proximal tumors, and partial gastrectomy for distal tumors. Need some margins as noted there. Reconstruction with a Billroth 2 versus a Roux Y, and then adjuvant chemorabs should definitely include the fluorouracil, as well as cisplatin or epirubicin. The extent of nodal sampling is highly debated. D1, D2, D3, and D4 resections include the farther away the lymph nodes are from the stomach. D1 are typically lymph nodes that are just right along the stomach, and D4 resection, those lymph node basins are like down right next to the aorta, behind the pancreas. So a D1 or a D2, typically most Western surgeons perform a D1, and our trials have found that there's an increased morbidity with D2 resections. Japanese trials have not shown increased morbidity and have shown increased disease-free survival with the D2 resection. And currently the recommendations is that D2 resection should be attempted by experienced surgeons. Unresectable gastric cancers include distant metastases, invasion, or encasement of major vessels. Linitis plastica is diffuse infiltration of gastric adenocarcinoma through the wall of the stomach, and it has extremely poor prognosis. It's indicated for a total gastrectomy. And then always consider palliative surgery, even with unresectable lesions, as these can start to obstruct. For example, gastrojejunal bypass or stenting is certainly something that can palliate stage 4 patients. All right, final topic, hernia, inguinal femoral hernias, miscellaneous hernias, ventral hernias, umbilical hernias, and then their repairs. 2 more questions. A primary care physician calls you to refer to a patient for possible umbilical hernia repair. You meet with the patient who asks about the risk factors for development of an umbilical hernia. Which of the following factors puts an individual at the highest risk for developing such a hernia? A, male sex, age over 65 years. B, pregnancy. C, cirrhosis. D, body mass index of 25 to 35. E, smoking status. This could be kind of tricky. Answer is pregnancy. Women are approximately 3 times as likely to develop umbilical hernias as men, and up to 90% of women develop an umbilical hernia during pregnancy. Repair is only indicated if the hernia becomes incarcerated or strangulated. All right, I think this is the final question. 76-year-old woman presents to the ED with nausea, vomiting, and abdominal pain and groin pain. On examination, she appears thin and frail. The abdomen is distended. A tender bulge is present in the right groin, and groin pain is improved with thigh flexion. Laboratory data shows leukocytosis. What is the next step in management after placement of a nasogastric tube and initiation of fluid administration for resuscitation? A, urgent exploration. B, non-surgical management with admission to the hospital ward for nasogastric tube decompression and fluid administration. C, abdominal x-ray. D, reduction of the groin bulge and discharge from the ED. Answer is A, urgent exploration. She has an obturator hernia causing a small bowel obstruction.
I'm going to give you a 1-minute warning.
Okay, thanks. I'm almost done. So obturator canal, it's down here in the pelvis. Classic patient is an emaciated, multiparous elderly woman with recent weight loss, intermittent SBO. It's much more likely in females, greater on the right side than the left side due to the sigmoid colon. And you can typically approach it in an open or fashion or laparoscopic fashion, and you repair it much like many other inguinal hernias that we're all familiar with. Mesh is probably best. That's all. Thanks very much. Happy to take any questions.
All right. I don't see any additional burning questions in the chat, and it's probably about right. We're out of time anyway. So thank you very much, Tyler. That was very good, very thorough. We appreciate it.
Thank you.
And if there are other questions, just throw them in the chat. Maybe we can address them later. But next up, we're going to move on to Dr. Kavina Juneja from the University of Alabama. She is also a resident and will be talking to us about trauma and critical care. So take it away.
Good evening, everyone. I'm Kavina Juneja. I'm a trauma critical care fellow over at University of Alabama in Birmingham. We're going to go over trauma critical care. I'll start off with a little disclaimer. I think this is one of the most important topics on the ABSITE because trauma topics cover about 6% of the questions and critical care about 5%. So if you look at it, this is over 10% of the overall questions that you're going to be covering. Again, a disclaimer being this is not going to be a comprehensive review as there's way too much to cover. The first stuff we're going to talk over is the trauma topics. And the brief overview is we'll go over the ATLS assessment, a little bit about shock and resuscitation, and then we'll go over some trauma by systems. So firstly, everyone should have been through ATLS as part of their training already. So every trauma question, you want to assess it based on your ABCDs first. Firstly, looking at anyone that you're coming into your ER as a trauma activation, look at your airway. Is your airway secure? Are they awake talking to you? If they're not, you have to consider whether they need to be intubated. The guidelines based on major tests is always if your GCS is less than 8, they need to be intubated. If they have certain maxillofacial or neck injuries that are compromising their oropharyngeal airway status, they need to be intubated. If that is unsuccessful, the next thing you need to move on to is an emergent surgical airway, which would be a cricothyroidotomy. The image up here in the middle of the screen demonstrates where exactly your cricothyroid membrane is and where your emergent airway would be placed. That's directly below the thyroid cartilage and above the cricoid cartilage is where that membrane lies. And your incision would be made vertically on your skin, up and down, and then with a quick dissection with your scalpel itself. Next thing you move on to is an assessment of breath sounds. Then your circulation. You're just checking for distal palpable pulses to make sure that they are not in acute hemorrhagic shock that would require that to be addressed before moving on to the rest of your assessment. Next thing is disability. That's a quick gross assessment of their neurostatus, and that's where you want to start calculating your Glasgow Coma Scale. I have that over here on the right side of the screen for you to look over, but the main thing that you are considering in this is whether they have a moderate or major brain injury, and if their airway is secure, whether they need to be intubated. Questions usually will describe these findings to you. They won't mention the specific GCS score or number, and they want you to be able to calculate that so that you can figure out what the next steps need to be. The last thing would be exposure to catalog the rest of their injuries. So once you've done your ABCDEs, the rest of the stuff that needs to be going on during your initial assessment is assessing whether they have IV access and starting your resuscitation. Following that, the next stuff is getting appropriate imaging. Fast exam is pretty much required for every patient. And the views that you're going to be looking at your right upper quadrant to look for blood around your liver, left upper quadrant, look for blood around your spleen, your subxiphoid view to take a look at your cardiac chambers, rule out a pleural effusion, and then your suprapubic view to look for any blood fluid around your pelvis. In your extended fast exam, you can also look at the pleural windows to look for lung sliding and rule out a pneumothorax. The following adjuncts are going to be chest, pelvis x-rays, and possibly CT scans if they're stable and have a blunt trauma presentation. So we'll start off with a question. Kind of went over this, but this is something that I've seen in multiple tests. You are presented with a 29-year-old female who comes in as a trauma activation after suffering a GSW to her mouth. She's in distress, gurgling, unable to talk to you. The decision is made to proceed with an emergent surgical airway. And what are the anatomic landmarks where you would place this? Above the thyroid cartilage, below the cricoid cartilage, below the thyroid cartilage, or between the tracheal rings. So over here, it's mainly assessing that you know where exactly the cricothyroid membrane lies, and the answer would be below the thyroid cartilage. You want to go in below the thyroid cartilage, above the cricoid. So you have an 18-year-old male who just underwent operative fixation of facial fractures and had a trach placed 2 days prior. You're notified by the nurse that there's been about 10 cc's of bright red blood per the tracheostomy site. You go and evaluate the patient at bedside. You don't see any active bleeding. What's the next best step in evaluation? Are you just going to observe? Are you going to do a CT angiogram, a bronchoscopy, or just suction the tracheostomy? The answer here is that you should proceed with the CT angiogram. This question is trying to get you to think about that something. If the patient, for example, you're presented with a patient that's continuing to bleed and is concerned for hemorrhaging from around the trach site, the main way to control the tracheonominate fistula would be via sternotomy. And to temporize that, you'd want to put your finger kind of under their sternal notch and try and put some pressure directly on where your nominate artery is until you can get to the operating room. So another question, you have a 42-year-old female comes in after an MVC. She's already been intubated because of agitation. Started blood product resuscitation, but she remains hypotensive. What's going to be your next step? Do you take her for a CT scan? Do you repeat your fast exam? Or do you take her to the OR for either exploration of her chest or abdomen? So the answer here is to repeat your fast exam. You have a patient who presented in hemorrhagic shock after a blunt trauma. You don't have an exam that's pointing you towards either the chest cavity or the abdominal cavity as the source of their hemorrhage. Your initial tests are benign. Your fast exam was negative. However, now that you've started blood product resuscitation, it is possible that your fast exam turns positive. If that were the case, and you have a fast exam that directs you to either the thoracic or the abdominal cavity as the major source of bleeding, then you would be able to explore that cavity. But without that answer, you can't really say, I'm going to take them to the operating room. And the reason the answer isn't CT scan is because your patient's still hypertensive. You don't want to take them to the CT scanner while they're hemorrhaging. So moving on to talk about shock in the context of trauma, unless it's proven. So to focus on hemorrhage, a question that's frequently asked is what the signs are associated with a certain class of hemorrhagic shock. So class 1 of hemorrhage is considered when you've lost up to 15% of your total blood volume. Class 2 is about 15 to 30%. And that's where you start seeing signs of tachycardia and narrowed pulse pressure. So tachycardia is usually your first sign. Class 3 is where you've lost about 30 to 40% of your blood volume, and you start seeing hypotension. Class 4 is greater than 40% blood loss. The major thing to think about whenever you have an unstable trauma patient in hemorrhagic shock is that you have to stabilize their hypothermia, acidosis, and coagulopathy. Those are the 3 main things that are going to lead to acute death in someone that you don't have hemorrhage control on. or are working to get hemorrhage control. So say you're working through a patient and you're in the operating room, you've done your initial assessment, gotten hemorrhage control, but they're still unstable. There's a lot of times that the question will try and walk you towards saying, hey, they need to go to the ICU so that we can correct the trauma triad of death, which is hypothermia, acidosis, coagulopathy. That's something to always keep in the back of your mind if you feel like you've done all the interventions that you should have in the acute setting, but your patient's still unstable. So when you're looking at resuscitation in the setting of hemorrhage, you want to minimize crystalloid infusions. Traditionally, moving on to blood product. However, in the recent years, we know that that's not the correct way to proceed. And if you know they're in hemorrhage, your first choice should be blood products. And so the questions have started moving towards that. I believe you want to limit any crystalloid infusion to less than 1 liter if there's any concern of hemorrhage. And you want to do a balanced blood product resuscitation. If you have whole blood available, that would be your first choice. Otherwise, you want to do 1-to-1-to-1 resuscitation of packed reds, FFP, and platelets. I haven't seen questions move on to whole blood, so usually they're looking at component therapy in your questions. The next thing to consider is tranexamic acid. This has made its way into questions. So you want to give your patient 2 grams within 3 hours of your initial injury hemorrhage, because this reduces fibrinolysis and your risk of hemorrhage. There's no benefit to giving this after 3 hours from the index event, and there's actually been some associated mortality risk if it's given at that point. If you're initially resuscitating without hemorrhage control, you are going to be looking at goal-directed resuscitation and permissive hypotension. So your goal systolics that you're going for is about 90 to 100. And afterwards, you're going to be doing TEG-based product-guided resuscitation. I have seen TEG-related questions in a bunch of tests recently, and the main thing that you need to just memorize is what each component stands for. So the TEG stands for thromboelastogram. It's a viscoelastic assessment of your body's hemostatic ability. It's basically seeing how quickly your coagulation cascade starts to form a clot, the strength of your clot, and whether there's any lysis at the end. This graph kind of goes into all that detail, and it's something that you just have to remember. So your R time is the initial thing that is looking at the time to start forming a clot. R time is prolonged. That means you have deficiency in coagulation factors, so you need FFP. The next couple of numbers are your K time and your alpha angle. They look at the speed of fibrin accumulation, or the time until your clot reaches a fixed strength. And so if there's a deficiency in this, you need more fibrinogen. So the product that your patient needs is cryo. The next thing would be looking at maximum amplitude, which is your MA over here. That looks at the highest strength of your clot. And if there's a deficiency with that, your patient needs platelets. And the last thing is your LY30, looking at lysis. And if there's an issue with that, you are having excessive lytic activity, your patient needs TXA. So moving on to the first trauma system that we're going to be looking at is traumatic brain injury. So your initial gross assessment of TBI is just based on your GCS. If your GCS is between 13 to 15, you have a mild TBI. Anything lower than that is concerning for moderate or severe. The imaging who would require focused imaging to rule out traumatic brain injury is patients who present with a depressed GCS, if they have focal neurologic signs, of course, or if you're concerned for CSF leak or blood leak from their nose or ears. If anyone's intoxicated, so you can't rely on their neuroexam, or if they have penetrating trauma to the head or neck. And the main imaging study you're looking at initially is a CT head or a CTA head or a CTA neck, depending on your acute concern. So the main traumatic injuries that are encountered in questions: an epidural hematoma. They'll usually present it to you as someone who suffered a head trauma and then had a lucid interval followed by rapid deterioration. The vessel that's injured is going to be your middle meningeal artery, and this presents as a lens-shaped lucency on your CT imaging that is limited by your suture lines. The scenario that's usually presented is a young person who took a bat to the head or had acute trauma just to their temporal region. The next most common thing that you see is a subdural hematoma. That's usually your bridging veins, venous plexus that bleed. It will present as a crescentic lucency that crosses your suture lines. The patient in this situation is usually an older patient that fell. The next thing they go over is intraparenchymal hemorrhage. This is the most common hemorrhage seen in traumatic injuries, and it will be a bleed that you see in the parenchyma itself. Intraventricular hemorrhage is the next thing. If anyone has the intraventricular hemorrhage, they usually are at risk for hydrocephalus and end up getting interventions such as ICP monitoring. Subarachnoid hemorrhage as well. And then the last one that's a bit more chronic is a diffuse axonal injury. So if someone has a worse neurostatus than their CT would portend, say they just have a mild subdural or a small intraparenchymal bleed, but they're not quite acting right, you would follow that up with an MRI of their brain to rule out diffuse axonal injury. And what that is really shearing forces to the axons from rapid acceleration, deceleration that would cause diffuse scattered lesions. And it's usually associated with a poor prognosis in the long run. So which patients actually need intracerebral monitoring? It's going to be any patient with a depressed GCS below 9, or if they're posturing or their mental status exam is confounded by hypotension or other injuries. It's usually a ventriculostomy, that's a drain placed into the ventricle. So it allows you to both drain the CSF and also assess the need to assess what their pressures are. You'll see a peak ICP around 72 hours after injury. So you have to monitor them for at least 3 days once an ICP monitor is placed. Your cerebral perfusion pressure is your MAP minus your ICP. If someone has elevated ICPs and you want to reduce them, what measures do you do? Your goal ICP is going to be below 22. The measurements that you can do are elevate their head of bed, do some permissive hyperventilation to get a PaCO2 goal of around 32, 35, and hypertonic saline bolus. Your sodium goal is usually 140 to 150, a higher sodium goal for worse prognosis. You can give a mannitol load. The side effect with mannitol is that it can cause hypotension as a result of osmotic diuresis. So that's something that you want to avoid in a patient who has acute hemorrhage. Make sure they're adequately sedated. And if that's not working, then you can move on to the next stage of paralysis with neuromuscular blockade agents, or even a deeper coma with phenobarbital. And then, of course, your operative intervention with a craniotomy or ectomy. They get seizure prophylaxis for 1 week. You want to correct their coagulopathy because everyone with a TBI has tissue factors that are released and will have some degree of coagulopathy. And you want to give them early enteral feeding. Spinal cord injury, the main thing you want to differentiate is whether they have neurogenic shock or spinal shock. Neurogenic shock is the one that would have changes in your hemodynamic parameters. You would have hypotension and bradycardia. Spinal shock, you usually only have some sensory motor deficits and no hemodynamic changes. A couple of syndromes that are focused on in questions is central cord syndrome. That's where you'll have upper extremity sensory motor changes, but not in the lower extremities. This is usually seen in a patient that's older and already has some baseline level of cervical stenosis. And this is a stretch type injury. Brown-Séquard, something that was heavily focused in medical school, so everyone should be quite familiar with. It's a hemitransection of the cord, usually as a result of penetrating trauma. You'll have ipsilateral motor deficits and contralateral pain temperature deficits. Anterior cord syndrome is usually seen with vascular injury to the anterior spinal artery, so you'll have motor deficits below the level of injury. Moving on to neck trauma, that's divided into a discussion between penetrating and blunt trauma. Penetrating trauma is There's vascular injury, and then in order to control this, you would require sternotomy because you're looking at proximal injury to your aortic arch vessels. If they're hemodynamically stable, you would work this up with bronchoscopy, EGD, esophagram, CTA. You need to rule out injuries to your esophagus and your tracheobronchial tree in addition to vessels. A zone 2 injury was classically taught to be something that definitely needs to go to the operating room because this is from your cricoid cartilage up to the angle of mandible and is the highest risk for injury to your esophagus, your trachea, and your carotid IJ vessels. Zone 3 injury is from your angle of mandible up to the skull base. This is usually something that is managed by imaging before any intervention because these studies, this injury pattern is usually very proximal vessel injuries that are better managed with IR, or it is a proximal laryngeal injury. Questions will now try to help you decide where to proceed based on whether there's presence of hard signs of injury, airway injury, esophageal injury, rather than just zones. So even if you have someone with a straight up zone 2 injury, you would only take them to the OR if you have evidence of like gurgling from the airway, expanding audible bleeding, stuff like that. If you have someone with an esophageal injury, you want to rule that out by scoping them or getting an esophagram. If it's contained, you can observe it. If it's non-contained, they need to be explored. In the neck, you would explore it with a left endomyotomy to assess the entire mucosal injury and then repair it in 2 layers, and then have a muscular buttress over it. If it's extensive and you can't find it, you just widely drain it. Next up, if you have a tracheal injury, you want to secure your airway. Either if it's emergent and you haven't made it to the OR, you do a crike, or if you're already in the OR, you do your appropriate tracheal repair, usually with vicryl sutures, and then tracheostomy. If you have a thyroid injury, you usually just observe it or drain it. You're not doing a thyroidectomy in the acute trauma setting. If you're now talking about blunt trauma to the neck, you want to rule out blunt cerebrovascular injury. So that's injury to your carotids or your vertebral artery. Patients who would get ETA are those who fall under the following criteria. If they've had some type of severe hyperextension flexion mechanism, if they have focal neurodeficit, if they have skull base fractures or extensive midface fractures, Lefort 2 and 3, if they have C-spine fractures, especially involving the proximal transverse foramen, your C1 through C3, because that's where your carotids would run through. And then your treatment is usually aspirin, and if it's extensive, endovascular intervention. Moving on to thoracic trauma. So say you put in a chest tube for thoracic trauma, what output would tell you you definitely have to go to the operating room? If upon initial placement, you have 4 hours, or of course, if they're unstable. The other thing is if you have an acute diaphragm injury, what do? It's usually seen on the left in the case of blunt trauma. You would see an air fluid level in the chest on your chest x-ray, and you would want to repair an acute injury with a transabdominal approach because you want to rule out injury to your underlying vessel, your underlying structures such as your spleen, your mesentery, and so on and so forth. Repair is usually with permanent sutures. You only put in mesh if the injury is so extensive that you'd require it. Blunt aortic injury, it's usually at the site just distal to the curiosum, so it would present on your chest x-ray with a about it if you have a high rib fracture or you have a left hemothorax. Your grades of injury, this is something to know about because they'll just tell you someone has a grade whatever aortic injury and then ask you for the step of management. So type 1, you just have an intimal tear. Type 2, you have an intramural hematoma. Type 3, there's a pseudoaneurysm, and type 4 is a gross rupture. Initial management, if it is a lower grade, it's impulse control. Usually with of or night. So this is a question now about blunt aortic injury. You have a 20-year-old presents injury of their proximal descending thoracic aorta. The patient undergoes endovascular repair of TVAR. Post-op day 2, they're noted to have cool, clammy left hand with motor sensory deficits and decreased pulses. What's your next step? Do you realign the thoracic aorta because they have an endoleak, a carotid subclavian bypass, an open repair of your thoracoabdominal aorta, or a brachial embolectomy? The answer here is a carotid subclavian bypass. Is usually on your TVAR, you're covering up your patients. They'll have diminished vascular supply to their left upper extremity. And that's what this question stem is pointing you towards. They need that bypassed with a carotid subclavian. Next thing, looking at penetrating trauma to your chest. The main stuff to be worried about with cardiac injury is if you have a penetrating injury to your box, which is superior boundary is your sternal notch, inferior is your xiphoid, and it's medial to your nipples. Usually you would start off with doing a fast. If you have a positive pericardial fast, you do a pericardial window and sternotomy is needed. Other thing to look for is blunt cardiac injury. Usually you see that with sternal fractures, proximal rib fractures, or if they have bruising to the chest. Most common EKG change is going to be sinus tach and PVCs. Most common arrhythmia is going to be SVTs. And you would want to get screening troponin EKG. If that's abnormal, they need to move forward with an echo. The next few slides go over what type of operative approach to do to access different injuries. I've just listed them here. I'm not going to go over them just for sake of moving along, as this is something to just memorize. Abdominal trauma. So for your small bowel, say you have a CT scan after blunt injury and there's free fluid, but no obvious solid organ injury, you want to rule out injury to your hollow viscus, especially if there are signs of bowel wall thickening, of mesenteric stranding, hematoma. You only explore mesenteric hematoma if it's expanding when you're looking at it in the operating room. And which small bowel injuries would you repair versus resect? So you would resect anything that's greater than 50% of the circumference, or if it's devascularized. And if you have multiple small injuries that are in pretty close proximity to each other, you want to take out that entire segment. So if you have moving on to colorectal injuries, you usually want to resect that injury following similar guidelines based on small bowel, if it's greater than 50%, if it's devascularized. Whether you do an anastomosis at that point or bring up a colostomy is dependent on their shock resuscitative status. So the question stem will tell you something about their stability. If they're unstable in any way, you don't want to do an anastomosis at that point. Rectal injuries, if it's intraperitoneal, you want to either repair or resect it and then drain with a diverting ostomy. If it's extraperitoneal, all you have to do is just divert it, and then you can try repairing it either transanally or doing a dissection, but usually the answer is just diversion. So moving on to solid organ injuries in your abdomen, so your liver. If you have a liver laceration and your patient's unstable or has continued transfusion requirements, it's a failure of conservative management. The patient either needs to go to IR for angioembolization or bleeding liver. Your first step is going to be packing, then use of hemostatic agents. And then you can do other things that you can do is putting in big sutures to kind of reapproximate your parenchyma, or resecting. And your resection in the setting of trauma is usually non-anatomical. If you have a retrohepatic caval injury, this is very rarely seen in questions, but just in case it comes up, those patients may need an atriocaval shunt or a Schrock shunt in order to stabilize them. But they're usually dead before they get to you if they're actively bleeding. Moving on to look at CBD injuries. So if you have a bile duct injury that's less than 50% of the circumference, you're going to repair that over a stent. Greater than 50% of circumference, you might need to do a choledochojejunostomy, and then all these patients would require wide drainage. If you have a portal vein injury in the acute setting, you can ligate it, but you have greater than 50% mortality for those patients. So moving on with a question. You have a 36-year-old who was discharged from the trauma service 5 days after hospitalization after having an MVC. He had a femur fracture that was operatively fixed, and he had also had a grade 4 liver laceration that was conservatively managed. He presents to the ER 1 week later with large volume hematemesis. What's the most likely intervention to treat what the underlying pathology is? Endoscopy, angioembolization, gastrectomy, or nasogastric decompression. So in this setting, they're trying to point you towards the patient having hemophilia as a side effect, as a consequence of a grade 4 liver laceration that was non-operatively managed. And the fastest, most expeditious way to take care of this would be angioembolization. Say you have a patient with a splenic injury, similar to managing your liver injury. If they're hemodynamically stable or have continued transfusion requirements, they need to either go to IR or OR for management. There's been a lot more literature for IR management of splenic injuries so that you can conserve some of your splenic tissue. Usually in your question stem, they'll make it pretty obvious or only give you one of the two options so that you don't have to differentiate between IR versus OR, because that's a bit more nuanced than most tests actually get into. Make sure that anyone who goes through either either gets a splenectomy or a splenic artery embolization gets their post-splenectomy vaccines, which is going to be your H-flu, meningococcus, and pneumococcus. Looking at duodenal trauma, blunt trauma, you usually see the most common duodenal injury they'll tell you is a hematoma, usually in the third portion. These patients may develop small bowel obstruction symptoms about 72 hours after injury, and it's usually due to edema. If this is the only injury and you are otherwise managing them conservatively without a reason to go to the operating room, you'd want to manage this kind of like any other small bowel obstruction with nasogastric decompression and parenteral nutrition. If they're still not opened up by 2 to 3 weeks, that's when you're pushed to go to the operating room to either open up the hematoma or do a bypass. If you're already in the OR and you see a decent duodenal hematoma, you want to open that up if it's greater than 2 centimeters. If you have a duodenal laceration or perforation, it's most commonly seen in the second portion if it was due to a blunt trauma. You want to either debride it and do a primary closure or do an end-to-end anastomosis. In either setting, you would do wide drainage. They usually would make it very clear in the question stem if you're going to be narrowing the lumen with primary repair, or if it's too close to the ampulla to be able to do a primary repair. And in that setting, you'd be pushed to do an anastomosis. And that's usually if you're pushed to do either an anastomosis, they're going to ask you to do either a DJ, a pyloric exclusion, or a jejunal serosal patch. Looking at pancreatic injuries, that's managed basically if you just have a contusion, no ductal injury, all you're going to do is drain it. If it's distal enough, but has a duct injury, you're going to do a distal pancreatectomy, usually with splenectomy in the trauma setting. If it's a pancreatic head injury involving the duct, initially all you're doing is wide drainage and then managing it endoscopically with ERCP stenting. In very rare setting, you would move on to a delayed Whipple. This is usually not seen in question stems for tests though. Retroperitoneal hematomas, if they're a result of penetrating trauma, you always explore it. If it's a result of blunt trauma, your exploration depends on whether it's expanding or not. So zone 1 hematoma, if it's, which would be an injury to your aorta or IVC, you always explore. Zone 2 to kidneys flank, you only explore if expanding. Zone 3 pelvis iliac, you usually just pack and then take them to IR. You would only explore it if it's uncontrolled in the setting of like a major iliac vessel injury. Moving on to urologic trauma. So renal trauma usually presents with hematuria. You want to investigate it with a CT scan. You want to make sure you get delayed phase imaging, which is a delayed venous imaging to get a better look at your ureteral collecting system. And then penetrating trauma to the kidney, always explore. Blunt trauma, only explore if it's an expanding hematoma. How do you repair your ureter if it's injured? If it's proximal upper 2/3, you repair it over a stent. If you can't repair it, you do a nephrostomy to divert, and then in a delayed fashion, consult urology to take care of it. If it's distal, lower third, you're going to re-implant your ureter onto your bladder. If your ureter doesn't reach your bladder, you can mobilize your bladder and anchor it to the psoas muscle and then do a psoas hitch. Again, with this, you want to drain it. If you have a bladder injury, if it's extraperitoneal, all you need to do is Foley decompression for 1 to 2 weeks. If it's intraperitoneal, that needs to be repaired in 2 layers. If you have a urethral injury, that usually presents with symptoms of blood at the meatus, a scrotal peritoneal hematoma, or a high riding prostate on DRE. You want to do a retrograde urethrogram to take care of that. Pelvic fractures are very frequently tested. If you have an open book pelvis on your x-ray, and it will usually be associated with hypotension. Your steps to take care of it is a pelvic binder. And then if they're transiently responding or hemodynamically stable, angiography. If they're unstable, they go to the operating room for preperitoneal packing, followed by orthopedics to put in an X-fix or repair your pelvis. You want to rule out injuries to adjacent structures, usually things like your rectum, vagina, bladder, and urethra. So if you have penetrating abdominal trauma, let's say you have an abdominal stab wound, you go to, obviously hard signs to go to the OR. If they're unstable, they have peritonitis, you see eviscerated omentum or bowel. If it's an anterior stab wound and your anterior rectus sheath is violated, but nothing else, you can just do a CT and observe with serial exams, or you can go to the OR for a diagnostic laparoscopy and investigate your fascia. If it's a flank stab wound with risk for retroperitoneal injury, you want to look at it with a triple phase CT if they're stable. Thoracoabdominal stab wounds, you usually start out by looking in the abdomen, and then you definitely have to rule out a diaphragm injury and make sure you repair that before you finish whatever repair you're doing. Moving on to extremity trauma, the main thing that they will test you on is vascular injury. So if you have any hard sign, they're going to go to the operating room. Pulsatile bleeding, expanding hematoma, absent pulses, bruit, throw. If you have soft signs, like maybe they have a hematoma, maybe they have discrepant ankle brachial indices, you have time to get a CT angiogram to better plan your repair and then decide if it needs to go to the operating room. For rule of thumb, if you have a major arterial injury that needs a bypass, you're going to repair it with reverse saphenous vein grafting from the contralateral limb. If it's a venous injury, you can either primarily repair it or just ligate it. And then always consider fasciotomies if you've had diminished arterial flow to your limb for at least 2 hours. So a question about extremity vascular trauma. If you had a 32-year-old male presents after a GSW to the left thigh, he's hypotensive with systolics in the 60s. We have an increasing hematoma with pulsatile bleeding, taken emergently for operative exploration. You find an injury to your superficial femoral artery with a 2-centimeter defect between the proximal and distal ends. How are you going to repair this? Primary repair, an SFA interposition with PTFE, SFA interposition with reverse saphenous vein, or just ligate the SFA. So the answer here is you're going to do an interposition graft with vein. You definitely have to restore flow to your SFA. Primary repair in this setting is impossible because you have 2 centimeters between your proximal and distal ends. And you want to avoid using any prosthetic material in the setting of this dirty wound. So last topic in trauma is if you have a pregnant patient, you always prioritize the mother first. And you have to have a high suspicion of hemorrhage in them, even if they don't have hemodynamic signs that are pointing you towards that, because they can lose 1/3 of their blood volume without any signs.
Kavina, 1 minute.
If they have any abdominal trauma, you want to rule out placental abruption and maternal fetal hemorrhage. Usually that's associated with a high risk of fetal mortality. And you only do fetal monitoring if they are beyond the age of viability. So that's 24 weeks gestational age. The indication for C-section is if you're already in the OR, your mother is in maternal shock, you have DIC, or you need to evacuate the uterus in order to get to the mother's injuries to adequately repair them. The last thing I was going to go over was critical care topics, but it seems like I'm out of time. Those are pretty self-explanatory and have stuff that you just mainly have to memorize. So I'm just going to go over the slides so that they'll be recorded for you to be able to review on your own. Ventilator management is mainly to look at what is primary extubation criteria. And then management of ARDS.
You can go through the slides and maybe we can also come back to it at the end if we have more time. So but yeah, you can scroll through the slides and then if Thomas finishes up a little early, then we can come back to it.
Okay, definitely. ARDS is also quite frequently tested. There's a question on extubation criteria there, and this is vasopressors, just to know what the major receptors that they act on and when to use them. Cardiovascular physiology, I put the main equations that I've seen tested frequently, and then also parameters of different shock. There's a question on sepsis, PE management, what the signs and symptoms are when you do anticoagulation versus any intervention. Nutrition, this is one of those things that you just have to memorize. Looking at respiratory quotient, how to calculate your nitrogen balance, daily caloric needs, source of nutrition for your colonocytes, enterocytes, and then acute kidney injury, hemodialysis, how to work that up, and who needs dialysis. This is just a question on reversal of coagulopathy, and then this is a question on compartment syndrome, and that was it. I can go over any questions if there are.
Great, thank you. There were a couple of questions in the chat. I think the main gist of it is, keep it simple. I'm a follow the KISS rule. I think that sometimes there's a lot of different things that you would do in real life, but I think that when you're in a board situation or a test situation, just do the simple textbook answer. And other things are always think about getting a patient off the table if they're critically ill. So don't do a time-consuming procedure. Your goal is damage control, and that's kind of how the board examiners and also people who are like running these tests, they want to make sure that you're a safe surgeon first and foremost, so that you'll do the safest option, even if it's not the most fancy, slick option. So I think that's where it's really important to distinguish like what's done at your own institution. So anyways, we can come back to us if we have more time, but I'd like to introduce our next speaker. Dr. Thomas Ward, who will be talking to us about colorectal and small bowel topics for the ABSITE.
Excellent. Thank you everyone for having me. I'm excited to get a chance to present here. And I'll be talking kind of a big topic between both colon and rectal and also anorectal and small bowel disease. So we'll try and fit up at least the highlights in right now. So as some disclosures, I do receive research support from the Olympus Corporation, but that will have no bearing on the talk today. So let's start off with the first question. So we have a 58-year-old woman who undergoes a flexible sigmoidoscopy for hematochezia, which reveals a 4-centimeter sigmoid mass at 40 centimeters. The biopsy is positive for adenocarcinoma. Other than occasional hematochezia, she's asymptomatic and wants to pursue surgical resection. What should her ensuing preoperative workup include? A, nothing, straight to surgery. And then you see a couple of variants here. A CBC, chemistry, CEA, CA19-9, PET CT of the chest, abdomen, pelvis, and colonoscopy. C, which is the same as the above, but changes the PET CT for a regular CT. D, CBC, chemistry, CEA with a CT of the chest, abdomen, pelvis, and a colonoscopy. And then lastly, E, CBC, chemistries, CEA, brain MRI, CT of the chest, abdomen, and pelvis. So the answer is D, and we're going to go over why here. So preoperatively, whenever you get somebody who has colon cancer, first you want to determine a tumor baseline, figure out if the patient can actually tolerate an operation, see if they're resectable, and then try and figure out what you're actually going to do in the operating room. So what does it mean by a tumor baseline? That's a basic CBC where you're trying to see, for example, if they've had any iron deficiency anemia due to a tumor. Chemistries, including a baseline creatinine and BUN, in addition to liver function tests to see if they have any liver metastases, and a CEA. The one thing to note is CA19-9 is not a tumor marker for colorectal cancer, so you should not order this. It's not indicated and won't help you in your management. Next, you want to find out, is the person medically operable? And that's their fitness. So both in terms of a cardiovascular standpoint, can they handle it, pulmonary status, and also do they have adequate nutrition to be able to heal from whatever surgery you're about to do? And then next, you're trying to determine, are they primarily resectable? So you want to see, do they have any liver peritoneal disease? For that, you get a CT abdomen pelvis with IV contrast. Next, you want to find out where's the second most common source of mets. It's the lungs. So you do a CT of the chest. Now, a key point here is you do not need IV contrast for this. Typically, we do because we get it at the same time as the abdomen and pelvis. But if you get a patient coming into the emergency department who already got a CAT scan with IV contrast, you do not need to give them a second IV contrast load. And then next, you want to determine what's the extent of your resection. So one, that's the location of the primary tumor. In this patient, they had a flex sig that showed us in the sigmoid colon. However, one of the key points was they didn't have a completion colonoscopy. You don't want to be the person who does a left colectomy, and it turns out the patient already also has a right-sided tumor. So now you've hooked up bowel that has tumor to then bowel that you've then resected from. Okay, question number 2. A 58-year-old woman undergoes now a colonoscopy for metachesia. This reveals a 4-centimeter mid-rectal mass at 7 centimeters. Biopsy is positive for adenocarcinoma. Other than occasional hematochezia, she's asymptomatic and she wants to pursue surgical resection. All of her labs are unremarkable. Staging CT shows that she has no metastatic disease. What's the next best step in her care? So you have A, perform a low anterior resection. B, chemoradiotherapy followed by a low anterior resection. C, endorectal ultrasound. D, transanal local excision. Or E, pelvic MRI. The answer is pelvic MRI. So we've already covered preoperatively the colorectal cancer pre-op workup. So 1 through 4 we've covered. Whenever you have rectal cancer, the next differentiator is you need to see, do they need neoadjuvant therapy? Rectal cancer, unlike colon cancer, about 50% of the recurrences can be local rather than being distant. And so we found the benefit to getting preoperative chemoradiation therapy. So you need to determine, do they need this prior to going for a resection? Now, who needs neoadjuvant therapy? It's those who have a T3 or T4 tumor and those who have positive nodal disease. That means at least one lymph node is suspicious and they're through the muscularis propria or deeper for their tumor. So how can you actually determine TNN without final pathology, right? You haven't cut it out, you haven't sent it to the pathologist. What you do is either a pelvic MRI, which is the preferred method. No contrast is required for this. And the key thing is getting good slices of T2 cuts. T1 can help you determine if the tumor is evaded to the bone. But whatever you look at this and you want to look like a pro, you want to immediately go to your T2 series to be able to determine how deep the tumor is and to also look for any positive and suspicious lymph nodes. And then another alternative is endorectal ultrasound. This has actually been found to be inferior to MRI and is less accurate, but you have to use it if MRI is contraindicated. For example, if a patient has some sort of metal implant that would not be compatible with being in an MR. Okay, question 3. A 58-year-old woman undergoes colonoscopy for metachesia, very similar stem to the previous 2, which reveals a 2-centimeter midrectal mass at 5 centimeters. Biopsy is positive for adenocarcinoma. There's no evidence of any lymphovascular exhasion nor any perineural invasion. Other than occasional hematochezia, she's asymptomatic and she wants to have a resection. All of her labs are unremarkable. Staging CT of the chest, abdomen, and pelvis shows that she has no metastatic disease. And the MR that you got, because you wanted to stage her local invasiveness, shows that she has a T1N0 tumor. What's the next best step in her care? A, low anterior resection. B, chemoradiotherapy followed by low anterior resection. C, endorectal ultrasound. D, transanal local excision. And E, abdominoperineal resection. So the answer is D, transanal local excision. So what we need to be able to then know is, when is transanal local resection appropriate for rectal cancer? Because in doing so, you're getting a full rectal thickness excision, so you're removing the local cancer. But what you don't do is get your lymph node harvest, so you have no idea about anyone having positive nodes. So you only want to do this for tumors in which you think that resecting only the lesion itself and not getting nodes will help give you for a curative intent. Which means you need a tumor that does not invade very far, so T1. There cannot be any positive nodes on MRI or CT that are suspicious for it, again, because of the fact that you're not going to be resecting them with just a local resection. And you have to have a favorable biopsy. So what does this mean? no lymphovascular invasion, no perineural invasion, and has to be well to moderately differentiated. And last, they have to have favorable anatomy for a complete resection. This means it's less than 30% of the bowel lumen, less than 3 centimeters in size, and you need to be able to get to it from the anus. You can't have something 60 centimeters up in the colon and trying to be able to whack it out locally. Okay, question 4. A 78-year-old woman, history of 8 childbirths and occasional fecal incontinence, undergoes a colonoscopy for metachesia, which reveals a 1.8 centimeter midrectal mass at 2 centimeters, biopsy positive for adenocarcinoma. There's no evidence of LVI nor PNI. Other than occasional hematochezia, she is asymptomatic and wants to pursue surgical resection. All labs unremarkable. Her staging CT of the chest, abdomen, pelvis shows no metastatic disease. Your local staging with MRI shows that she has a T3N1 tumor. She undergoes neoadjuvant therapy with tumor and nodes still noted on repeat flex sig and MRI. What's the next step, best step in her care? A, low anterior resection. B, systemic chemotherapy. C, close clinical surveillance with repeat pelvic MRI and sigmoidoscopy. D, transanal local excision. And E, abdominoperineal resection. So the answer is E, APR. So our key here is figuring out, why is this person a LAR, not an LAR, but rather an APR? So in order to determine this, you, 1, need to see how far you need to go with your resection with respect to the sphincters, 2, preoperative continence, and 3, patient preference. So with an APR, the tumor, if it involves the anal sphincter levator muscles, the patient's no longer going to have any continence whatsoever. So you need to do that APR, both in terms of continence, but more importantly, in order to get actually a negative resection. In terms of 2, you also, your distal margin required will lead to loss of your anal sphincter and incontinence, like I mentioned. 2, you need to be able to assess their preoperative continence. So ask them about previous vaginal childbirth and their baseline gas or stool continence. You don't want to do a low LAR or even a ultra low anterior section if the patient already is leaking stool and gas. That's just a way to set them up for nightmares. Let's move on to question 5 now. A 78-year-old man this time presents with diarrhea and symptomatic anemia. A CAT scan of the abdomen and pelvis reveals a large distal transverse colon mass with evidence of peritoneal lesion and a small bowel tumor fistula. Colonoscopy is positive for adenocarcinoma, and the tumor was unable to be traversed with a regular colonoscope. What's the next best step in this patient's care? A, diverting transverse colostomy. B, extended right colectomy. C, extended left colectomy. D, systemic chemotherapy. And E, chemoradiotherapy. So the answer is D, systemic chemotherapy. So the key thing to note in here is the fact that the patient is still presenting with diarrhea. And that helps you decide on this question, because you need to be able to know what are the indications for an operation in unresectable or locally advanced cancer. What would bring you to go there instead of treating them with chemotherapy up front? And 1 is obstruction or immediate obstruction risk. This patient who's having diarrhea, has no evidence of any nausea or vomiting, isn't obstructed, so that's not an indication for you. The second is significant bleeding. Oftentimes you can try and control this with interventional radiology, but due to the hypervascularity of these tumors, you ultimately just have to take out the tumor. Or 3, perforation. Now, whenever you have a patient who's coming in obstructed with a cancer, you have 4 of these really acceptable options. 1 is just to do a proximal diversion. Doesn't help their cancer whatsoever, but it does cure their obstruction, gets them out of the hospital quickly and gets them to chemotherapy. 2, you can attempt to do a resection as long as you do an adequate lymphadenectomy and give them a proper cancer operation, which for colon cancer and colorectal cancer is less than or equal or greater than or equal to 12 nodes. You can try and stent them, though this is starting to fall out of favor and is really just seen in select cases of distal lesions in the colon that are amenable to stenting, with a plan for a later resection. Or 4, do some variant of an intestinal bypass. Now I'll move away from colorectal cancer to a different sort of pathology. So question 6 is, a 45-year-old man is taken to the OR and undergoes appendectomy. Gross pathology reveals the following, which is noted at the midsection of the appendix and measures 2.3 centimeters in greatest diameter. What is the next best step? A, referral for port placement and chemotherapy. B, follow-up in 6 months with a CT of the chest, abdomen, and pelvis. C, CT of the abdomen and pelvis. D, right hemicolectomy. And E, no further follow-up needed. So when you're looking at this image, be careful to look and see in terms of what's the morphology, see where the appendix limit is, and see what's adjacent to it. Now the answer is actually C, CT of the abdomen and pelvis. So for those who don't know what the diagnosis is, this is an appendiceal carcinoid. And the appearance is a mass that is firm, yellow, and bulbar, which is actually what we see here. Yellow, bulbar, and you can imagine if you were to touch this, it'd feel firm. Now, what we have to then figure out is what's the treatment, appendectomy versus a right colectomy. Now, an appendectomy suffices if the tumor is less than or equal to 2 centimeters, which is not true for our tumor in this question, Sam, it's 2.3 centimeters. If there's no positive nodes or margins, and as long as you have a complete resection rather than an incomplete resection like I put on here, which means you have to not have a tumor at the appendiceal base, because if you're taking the base, that's where the tumor is, you have to technically have a positive margin. Now, if you decide not to do your right colectomy intraoperatively, for example, you don't notice this and you see it on final pathology, or if the patient is doing clinically okay and can wait for the OR, you really should be doing a CT or an MRI of the abdomen and pelvis with IV contrast. And the key here is ensuring that the patient has resectable disease. If they have widely metastatic neuroendocrine tumor of this carcinoid, then resecting the primary does not yield them any terms of survival benefit. And so you'd be putting them through an unnecessary operation with morbidity and mortality attached to it. So for this question, that's why doing a CT scan was the correct choice first, because you need to do staging before going on to do an operation, just like we do with any other cancers. Now, there's another variant on appendiceal carcinoid that you need to know for the test, and that's just knowing when to treat it as colon cancer. Now, carcinoid typically is a neuroendocrine tumor, but sometimes you treat it as colon cancer, both in terms of staging, your workup, your resection, and how you follow them. And that's whenever you have pathology that shows evidence of an adenocarcinoma. So what are kind of keywords that you'll need to look out for on the test? Well, one is an adenocarcinoid, and the second is a goblet cell carcinoid. Both of those two things should be treated as if they were adenocarcinoma rather than an appendiceal carcinoid. Okay, next question, moving away from cancer. So question 7 is, a 75-year-old man presents with abdominal pain and distension. Plain abdominal radiograph is shown to the right. The patient is stable and has a benign exam, complains of no tenderness whatsoever other than feeling like they're very, very bloated. What's the next best step in management? A, sigmoidoscopy and decompression. B, nasogastric tube placement and observation. C, cecopexy. D, right hemicolectomy. And E, sigmoidectomy. Now, the correct answer is right hemicolectomy. So what this question requires you to do is, 1, figure out the diagnosis. In this case, it's a cecal volvulus. And then second, know the appropriate treatment for the cecal volvulus, which is a right hemicolectomy. Now, how can you actually recognize the cecal volvulus? One of the more frustrating things in the ABSITE is you get not even just a plain film, but sometimes they'll give you a single slice of a CAT scan. And we're used to being able to scroll up and down and be able to put together the 3D picture, but you get a single one. So you often get these kind of either, instead of buzzwords, buzz pictures, where you have to be able to see it and then be able to identify the diagnosis. So for a cecal volvulus, they'll typically be in the left upper quadrant to right upper quadrant, right lower quadrant direction. So you see it starts here and moves up here. There's no dilation of the descending colon, right? If you have a sigmoid volvulus, you're obstructed the sigmoid colon. So you should see some dilation as things aren't able to progress forward. This left descending colon looks pretty darn normal. And then you have a normal appending sigmoid colon, which you see as this trails down here. That's the one that is kind of the key thing for me, is looking to see, is the sigmoid normal? Because at first you see this, you see a large kind of twist, large bowel in the person, you may be able to say sigmoid volvulus, and you spend a little while hemming and hawing about what it is. So look for that normal sigmoid colon to be able to differentiate on a plain radiograph. Here's a picture of a sigmoid volvulus, which again, looks pretty similar, but you'll notice that there is dilated descending colon, which helps you out. And there's no normal sigmoid colon. The sigmoid colon is quite large and twisted on itself. You may hear about the bird beak finding. That's what I've seen if you do it on a fluoro study, or if you give them rectal contrast on a CT scan, where you see the two fluorinated loops coming together and being pinched off. It'll often be in a right upper quadrant to left lower quadrant directions, though not always. And like I said, dilation of the descending colon. Now, in contrast to a cecal volvulus, where the correct treatment is to go for a right hemicolectomy, we know that cecopexys just recur and come back. The initial treatment in a stable patient who has no signs of generalized peritonitis is that they should undergo endoscopic decompression. Second, they be bedside with a rigid scope or in the endoscopy suite with a flexible sigmoidoscopy. And then the goal is usually to do a same admission sigmoidectomy on a more elective basis. These are typically very easy and quite honestly fun cases. It pops right out and it's easy to resect and put back together. Now, if the person is unstable, and they'll see this in the questions then, they'll have, a leukocytosis, tachycardia, low blood pressure, and signs of pain on exam rather than just signs of distension. They need to go for immediate sigmoidectomy because your concern at that time is that the bowel is compromised. There's no point in detorsing compromised bowel. You're just opening yourself up to blowing air in necrotic bowel and then spreading it throughout the abdomen. Okay, now moving on to question 8, anal rectal. So a 75-year-old man presents with anal pain and blood on his toilet paper. Physical exam is shown on the right. They've tried fiber supplementation, regular bathing, and they've had no relief whatsoever. All they're complaining of is a massive pain in their butt. They would like to move to the next definitive step in management. So what is the next step? 1, should you offer them a closed, aka Ferguson hemorrhoidectomy? B, should you give them acyclovir? C, should you do a fistulotomy? D, should you do a lateral internal sphincterotomy? Or E, should you give them hemorrhoidal artery ligation? So you want to offer this gentleman a lateral internal sphincterotomy. So the key here is 1, figuring out what the heck this is. If you see back on the question choices, I gave you options to treat hemorrhoids in terms of A and E, and treatment for those who have HSV of the anus, acyclovir, and those who have a anal fistula or a perianal from a perianal abscess, a fistulotomy. But that's not the right answer. This is an anal fissure. Now, you don't need to do a digital rectal exam in these patients unless you want to torture them when they're in your clinic, because what you see is, on spreading the butt cheeks, you notice this fissure in the posterior midline. That's exquisitely painful and tender. And this has been going on for a little while now because they have this sentinel pile, which is evidence of the fact that from the dashed line that it's been there for a little while. Now, if you spread the buttocks and you look there and you see that this longitudinal anodorm tear is not in the posterior midline, but rather on the lateral aspects or anteriorly, that's often a time when you need to suspect that maybe it's not just your run-of-the-mill anal fissure. And those patients will need a workup for other causes. One of the primary ones is going to be Crohn's. So you can often then scope them and see, do they have any other evidence of Crohn's disease? Because the treatment's not surgical. The treatment's doing medical management and optimizing their treatment for Crohn's. And you'll see questions that kind of will mention a non-posterior midline anal fissure on the ABSITE. Maybe there was one in 2017. I can't comment. Now, treatment for the anal fissure is 1, you start with maximal medical therapy. So what does that mean? You want to bulk their stools. You don't want them having diarrhea that'll irritate it. You want to get them nice formed 1 to 2 stools a day by giving them lots of fiber. They can do warm baths 2 to 3 times a day. We'll often say sitz baths where you'll go and find some solution to sit in. But honestly, just a warm bath is enough to be able to relax that anal sphincter. Because what's the problem? You're having pain, which is then leading to spasm of your anal sphincter, which is then ripping that thing open and causing more pain. So you're in this vicious cycle. So you're trying to break that cycle to be able to stop that spasm and give time for the tissue to be able to relax, get good blood perfusion, and heal. And you also do topical agents. Now, there's nitroglycerin, which historically have been used, and then nifedipine. The problem with nitro is it gets rather fantastic systemic absorption, so people often won't tolerate it. They'll get headaches, they'll get dizziness, and they'll get low blood pressure. Nifedipine also is available as a topical agent and will work. And the entire purpose of that is to, 1, have some vasodilation and promote healing, but 2, also just kind of cause some relaxation of that sphincter. In case you want to know a little bit of trivia, you also give the person just oral nifedipine rather than a topical agent. So this typically isn't as well tolerated because you're dropping their blood pressure. Another option is a chemical sphincterotomy. And so this is done with Botox or botulinum toxin. What this does is, instead of cutting through the muscle and stopping that spasm rip cycle, instead you give them a chemical sphincterotomy and you stop it from being able to contract with the Botox. You do this in the office or in the operating room. This is nice for some patients, particularly those that you're worried about their continence. If you were to do a surgical sphincterotomy, you can do the trial run, give them the Botox, see if it improves it, see if it heals it, and it wears off in a few months, so there's no bridges that have been burned. And last is the definitive management of a surgical sphincterotomy, which is your treatment and cure for about 90 to 100% of patients who have this. This is where you divide the internal sphincter. You can do this in a tailored fashion, which means that you only cut the sphincter up to the level of where the anal fissure is, or you can do a total sphincterotomy where you divide the entire internal sphincter. That comes with a higher risk of incontinence, but does come with slightly marginally higher healing rates. Okay, and lastly, question 9. Not lastly, second to last. A 89-year-old woman with a history of CHF, coronary artery disease, chronic obstructive pulmonary disease presents with an anal mass. Physical exam is shown on the right. The patient's tried fiber supplementation, they've tried bathing, and they've had no relief. They had no issues with constipation. The mass is 6 centimeters in size. They would like to move to definitive management. What is the best next step for definitive management? A closed Ferguson hemorrhoidectomy. B, mucosal stripping and muscle plication. C, perineal rectal sigmoidectomy. D, transabdominal rectopexy with sigmoidectomy. Or E, transabdominal rectopexy. The answer is C, perineal rectosigmoidectomy. Now, it's a bit mean to everybody here, and I took away the typical eponyms that we know these procedures by. So that would be an Altemeyer procedure, while the mucosal stripping and muscle plication is a DeLorme procedure. Now, rectal prolapse, the big thing is making the diagnosis. Don't mistake it for prolapse hemorrhoids, which have a radial appearance you see on the right. So radial is going inwards, rather than when you go back, you see these concentric circles of the mucosa. That helps you differentiate one versus the other. You don't want to be putting sugar on hemorrhoids, which, while can kind of get them to go in, isn't going to be able to help you reduce it much at all. And now when you see this person in clinic and evaluating them for an operation, you want to really determine how far is their prolapse. What you do is you have them bear down and sit on a toilet and see how far they're able to get it out. And like I mentioned, if somebody comes into the emergency department with an acute prolapse and pain, you can try and get it back into the belly. And how you do that is putting a ton of sugar on. I've gone to our coffee station here and asked for a whole bag of sugar and dumped the whole thing on. And what that does is the water goes out of the mucosa, so you get rid of that edema, and it helps you be able to put that back into their bottom. Now, when a patient comes in with rectal prolapse, it's driving them crazy and they want surgical treatment, there's a couple of varieties we can do. One is an abdominal procedure, which is more definitive and it's low recurrence risk, but it comes with the downside of the fact that you're doing a transabdominal operation on this patient. And for these frail, typically old, sicker patients, they don't tolerate that. But if they are able to do it, you want to offer it to them because of the fact that you're going to get better results. And the key thing you want to be able to figure out from them is, do they have constipation or not? When you do a transabdominal rectopexy, which means you mobilize the rectum, bring it up, and then suture it typically posteriorly to the sacrococcygeal fascia, that often causes patients to have a little bit of issues with constipation. So if they already have constipation, you're now going to exacerbate that for them. And so what you can do to help is get rid of some of that redundant colon and do a sigmoidectomy, and then suture the rectum after you do that. If they don't have constipation, then you don't need to do a sigmoidectomy, and you can just go straight to rectopexy. Now, if they're not a candidate for an abdominal procedure, then you can do a perineal procedure. We put the patient prone, and then you resect some of it. And now your question then is, how much prolapse do they have? If it's under 3 to 4 centimeters, then you do the DeLorme, which is a fun procedure. You go in, you raise a submucosal wheel, and you cut into the mucosa, strip it, and then you're left with the muscle layer in place. You plicate that down, and what that does is give you some nice bulk and a little bit of extra sphincter tone. And then you do an anastomosis of the proximal mucosa to the distal mucosa. However, if it's more than 3 to 4 centimeters, it just isn't practical. You'll have some patients who will pull out a foot or more of colon, and you can't be doing that entire submucosal dissection and just stripping the mucosa. And then you'd have a huge amount of muscle you'd plicating together. So instead, what you can do is an Altemeyer, which is a perineal rectosigmoidectomy. And what that does is a full thickness resection of the redundant tissue from the perineal approach, and then you do a anastomosis. Okay, now time for the last question. Hopefully catch up and get you guys out of here. So a 58-year-old woman with a history of Crohn's proctocolitis undergoes a surveillance colonoscopy. Mucosal biopsies from the proximal descending colon and sigmoid colon reveal dysplasia. What's the best way to manage this finding? A, continue with regular annual colonoscopy screenings. B, perform a left hemicolectomy, which includes the splenic flexure. C, do a total abdominal colectomy with ileorectal anastomosis. D, doing a total proctocolectomy with iliopouch anal anastomosis, or E, doing a total proctocolectomy with end ileostomy. So our options here are screening or doing a variant of many different resections. So the answer is E, total proctocolectomy with end ileostomy. So this breaks down a few different things and leads to a couple different points you should try and take from this question. One of which is you have a biopsy with dysplasia in a patient with either colonic Crohn's disease or a patient who has ulcerative colitis. What are you supposed to do? And so just narrowing this down, this is just random mucosal biopsies that are positive. The answer is take out the entire colon. And so if you have rectal sparing disease and Crohn's, you can do a total colectomy and leaving a little bit of a rectal stump, knowing that you're going to have to do very vigorous surveillance on that in case cancer does arise. Or for patients who have Crohn's or have ulcerative colitis or have rectal involvement with their Crohn's disease, it's a total proctocolectomy. So why do we take out the whole colon if there's only dysplasia, for example, on the right? If you look at Crohn's colitis patients through reviews of a few hundred patients, between 14 and 40% of them who undergo a segmental colorectal resection, so say you found right-sided dysplasia or right cancer, you cut it out, they're going to get a metachronous colorectal cancer, which means down the road, maybe even a few months, you're now going to be taking out their left colon. Actually, just took care of a patient like this last month who refused a total colectomy and figures that they came back 1 year later, having then take out their left side of their colon. Also, whenever you look at these specimens in final pathology, if you get a biopsy that says unifocal dysplasia and you look at it under final path, they actually have multifocal dysplasia, which means that it's much more pronounced than just what your few mucosal biopsies are hitting. So even if you said, oh, I only found it in the right colon, turns out they're probably going to have it more than a third of the time somewhere else as well. So you're just setting yourself at risk for getting another cancer down the road. So we've answered most of this question, right? We know that it's not screening, it's not a left hemincolectomy, and it's taking out the whole colon. But then the next question is, why not the iliopouch anal anastomosis, but instead an end ileostomy? Because that seems like it'd be totally fair. The key here is it's a patient with Crohn's disease. And while some people will do pouches in Crohn's patients, they have a much higher long-term pouch failure rate, both in terms of getting pouchitis, but a non-functioning pouch, having local infections, and worsening disease. You'll sometimes have a perfect candidate, someone who has no anorectal, features of their Crohn's, no fistulizing disease there, is young with great continence, and they can get, some pouch and have it work for about 10, 15 years. But by and large, and as a rule on the test, if a patient has Crohn's disease, you should not give them a pouch due to the fact that they're going to have a high long-term failure rate. And that's it.
All right, thank you. So, we do have a question that was just typed in. I'm sorry. It says that I thought there was a difference in the management with a low grade versus high grade dysplasia. Yeah, there's some mentions to that. I'm following the American Society of Colorectal Surgery guidelines, and in those they actually treat any dysplasia, either invisible, low grade, or high grade, as being the exact same. And so if you see dysplasia on a test, you should follow those guidelines and take out the whole colon. And I think that's some good advice in general, because we've had some discussion today about what do you do with the nuanced type of situations. And I think going back to guidelines, well-published guidelines, like society guidelines, is a really good way to decide what to do on a test. Any other questions? Also, this is a new format for us in general. We had done previously just a review instead of going through questions. And so the other one, so if you guys have any feedback on the format, we would really appreciate that as well. And then it said another question is, just to clarify, for UC, would you do the same treatment for dysplasia finding? So it's the same treatment. You need to take out the entire colon and also the rectum. For a UC patient, depending on their baseline continence, if they have good baseline continence, you think they'll do well with a pouch, you can offer them a pouch, or you can give them an end ileostomy. Both of those are acceptable. Okay, thank you. Any more questions on this topic? So a lot of people seem to like the questions. Do you like the combination of questions and some didactics, or do you want just questions? Because I think Sages does just questions. Okay, the combination is good. Excellent. All right, perfect. Yeah, I mean, for me, I think I also like the combinations. So excellent. So maybe we will give, so I want to respect everybody some time. If you have any other questions, you can kind of keep putting them into the chat. But maybe Kavina, if you do you want to go back to your slides, or do you feel like you kind of covered everything that you needed to cover?
I didn't have too much information, so it really depends on if everyone wants me to go over them, I can. Otherwise, they have access to the images, so I leave it up to the audience.
Okay, if anybody wants to view that, then please let us know. We only have 5 minutes left. Going once, going twice. Okay, all right. So the recording, I'm not sure if it will be available immediately, but I believe we're not saying the PowerPoint, but we will send the video as far as I know. Let me see what LK says. Okay, and the slides are going to be posted as well too, so you guys will have access to the slides. So, all right, fantastic. All right, well, thank you all for joining us. There's a second session coming up, so stay tuned for that as well.